From SVC, you don't want to puncture here, you want to puncture a bit lower. And we will see in further slides. But this is just to give you angiographic anatomy of the left atrium and aorta. Similarly, fluoroscopically, you don't see left atrium, but this was a patient with calcified left atrium. So we were able to see the calcium and see the boundaries. So I took this image for it so that we can have an imagination that where the LA is lying in lateral position. Similarly, in AP position, that's what I was discussing. ये पूरा LA calcified, पूरी boundary हमें पूरी calcified नजर आ रही है. Next is, before we proceed for the system, आप लोग originally इन चीज़ों को देख भी लेंगे. पीछे हमारे पास सामान है, डॉक्टर तारिक अशरफ, बाकी लोग मौजूद हैं. So we have got this Mullen sheet. Usually it's 8 French sheet, and it has got this 59 centimeter length, and 67. The dilator is around 8 centimeter longer than this one, and then this broken groove needle. But I always warn you, and I will always tell you that look at the inventory in your hospital before you are going for septal puncture. What is the inventory available and what are the lengths available? Because they come in different lengths. ये सिर्फ यही एक लेंथ की नहीं होती, और डिफरेंट लेंथ्स हैं जिसके अंदर ये चीज़ें आती हैं. इसलिए आप इसको चेक कर लें कि आपके पास क्या अवेलेबल है. As far as I know, this broken bone needle comes in different lengths. और आपको कॉन्फिडेंस ये है कि सिर्फ ये 3 सेंटीमीटर बड़ी है, 4 सेंटीमीटर बड़ी है, एंड यू आर पुशिंग इट फॉरवर्ड, और ये थी 10 सेंटीमीटर बड़ी. अभी आपके लिहाज से तो अभी आप वहाँ तक पहुँचे नहीं होंगे, और इसका वो एंड वहाँ से बाहर निकल चुका होगा. So we always go under fluoroscopy, but if you know the length, then you will be using this stuff. It will be safer for the patient. So how does it work? So it has got a pointer at the back. You will see original pointer available in this device. So there is a pointer, and when you push it forward, the needle comes out of the dilator, and this is the needle which will puncture the septum. We will see in steps. But what should be the pointer position? The pointer position is that when you have introduced this pointer into the patient, the pointer position towards the left of the patient. Patient is lying down on the bed, and towards his left shoulder is 3 o'clock. Towards his right shoulder is 9 o'clock, and 12 o'clock and 6 o'clock. So when we are puncturing, our optimal puncture position should be from 5 o'clock to 6 o'clock. What do we mean by 5 o'clock to 6 o'clock? What will happen? Because you don't know where will be the needle directing. So I've got this image with me. I'll go forward and then come back. We'll come back with this one. I just want to show you something. When you are puncturing and when you want to go for 3 o'clock or 5 o'clock or 6 o'clock, basically this is what happens. This is when your needle is directing 3 o'clock. You will puncture into aorta, because this is in 5-chamber view on echo. This is our right ventricle, right atrium. You will puncture into aorta, and your optimal puncturing area is from 4 o'clock to 6 o'clock. You want to puncture and enter into LA. So when you direct your needle from 4 o'clock, 5 o'clock, 6 o'clock, never 7 o'clock, never 8 o'clock. Because why it's important? Because in fluoroscopy, you are looking at the images in 2 dimensions. 9 o'clock or 3 o'clock may look same. It's directing towards you or it's directing posteriorly. 2 dimensions, you don't know whether this bullet is coming towards you or it is going towards away from you. You see only this end on things. So it's important to keep control on your hand. We will be discussing this thing in further steps. I'll go back on the steps of PTMC and septal puncture. So what we do is, usually we start with, as by convention, You take wedge pressure before the septal puncture. You know how stable your patient is. And then you, by convention, we take a baseline image. The advantage of this baseline image is that if by accidentally you cause cardiac tamponade, usually signs develop a bit late, patient may crash a bit late, but on fluoroscopy you can see double heart shadow and you can see signs of effusions developing. So if you have got this baseline of the heart image available, then you can easily differentiate from the baseline that there is any difference in the heart shadow. And then we take a 3.5 or 3.2 normal J-tip wire, and we take from IVC into SVC. And it's easier thing if your wire is straight, because IVC and SVC are in the straight line, in the same line. So if you push the wire, it will automatically go into SVC. But if it is difficult, you can take a multi-purpose and keep the tip straight and go up, you will go into SVC. Then comes in the Mullen sheet 8 French with the dilator, because dilator is basically protecting your needle. You're going to take the needle inside. If you take the dilator out, then it will puncture the Mullen sheet and it will come out of the Mullen sheet. So dilator is the protector for the valve, for the needle. So this Mullen sheet will go up. It doesn't matter which branch you are going in, because you just want to stay into main SVC and you have to drop down. Next is the broken bone needle going inside, and always go under fluoroscopy. And what will be your hand position in this one? You will see on hands-on session. There is a specific safety finger position so that your needle accidentally doesn't come out of the Mullen sheet. So Dr. Tariq Ashraf and Dr. Irfan and Dr. Shahid are here. They are here. They will discuss, and they will discuss this and this. That what should be your hand position when you are taking the system in. Next is that you bring the whole system down, and as I've told you, this your pigtail is your marker. Your pigtail is your marker, and if you want to puncture higher, you will stop at the level of pigtail. If you want to puncture lower, conventionally we try to puncture lower, and we go one vertical disc space below this pigtail marker. Next is that you have already stopped and you want to puncture lower puncture. So you keep your needle here, and then I want to know, I want to puncture anterior or posterior. Anterior means I am nearer to the mitral valve, posterior means I am away from the mitral valve. This is the image which we have just seen in this angiographic view, which we have already seen AP view. Your aorta is here, your needle is somewhere here, your tricuspid and mitral valve is here, and coronary sinus below. So if you go further lower down, you may drop into coronary sinus. So next is this image we have already discussed, that you want to rotate your needle, so because you want to puncture anterior or posterior. This is posterior LA wall, this is aorta or mitral valve, they are lying anteriorly comparatively. So where do I want to puncture? Usually we want to puncture from 4 to 6 o'clock. So this is lateral position. In this lateral position, as I told you, we can clearly identify our septum position. The septum has got this vertical part and a horizontal part, because in this view, as I have already discussed, LA is somewhere here, and this is aorta. So septum is somewhere ascending part, and there's horizontal part. A vertical part of the septum and horizontal part of the septum. We will see in further images. But this you will not see angiographically. अभी तो हमें नजर नहीं आ रहा कि vertical कौन सा है, horizontal कौन सा है. So by convention, what we do, we divide this distance, pigtail and vertebral disc, into 3 parts, and we try to puncture in the middle one. If you go further posterior, there are chances you will go out of the heart. If you go near to the aorta, you may puncture aorta, or if you even enter, there will be very less space for your system to work and go in and crossing mitral valve. We will be discussing this one in next half. So this is the proof what I told you. Usually we don't see this septum, but what happened in this patient, we accidentally punctured into vertical septum. Our needle was inside this septum and we injected dye. So once we injected dye, this dye dissected the septum and stained the whole septum. So I kept this image for anatomy, just for this, so that we know the anatomy, that septum has got this vertical part and this is horizontal part. What is the importance of puncturing vertical part और हॉरिजॉन्टल पार्ट? इस लैटरल व्यू इमेज के अंदर माइट्रल वाल्व कहाँ है? इस लैटरल व्यू इमेज के अंदर माइट्रल वाल्व आपकी तरफ है. Because we have just discussed that my heart, my left atrium is like this, or my left ventricle is like this. And this is anterior septum, and this is horizontal septum. And I want to cross mitral valve. How on earth is possible you enter from the front and you want to turn your system 90 degrees to cross the mitral valve? It will be very difficult. If you puncture the vertical part, it means you are entering into LA from the front. आप यहाँ सामने से एंटर हो रहे हैं और आप जाना चाहते हैं इधर, तो आपका जो स्टिफर सिस्टम है, इट विल नॉट अलाउ यू टू बेंड एंड गो इनटू LA. इसलिए वी ऑलवेज ट्राई एंड सी एंड ट्राई टू पंचर दिस हॉरिजॉन्टल पार्ट. Because once you enter from the below, your system will have all the room to move, and you can move it directly towards the mitral valve. We will see in further slides. And this is very important thing, that once you puncture, you always give dye and take a cine. You might have punctured into LA, or you might have punctured into aorta, or you might have punctured outside the heart. So if this dye is making whorls, and if it is staying and then washing away, then you are sure that I am clearly into aorta, into LA. And that's an important thing, before you proceed and you push the dilator and the sheet in. We will see in Dr. Irfan will discuss in complication portions. We have got this thing. So you puncture the septum. And I've learned from my seniors, Dr. Ishtaq used to do quite frequent, that he used to stain the septum. So once your needle is inside the septum, they give a little bit dye, willingly they get this dye and stain the septum so that you identify anatomically which was the part I punctured. तो septum stain करते थे, और फिर इसके बाद you puncture further. When the needle is in, you inject. And this injection is also important in a way that you know that how much this distance in the needle and this posterior LA wall, so that you can easily push the system forward. You know that this much I can push further. If I push for more than this, you may puncture the left posterior LA wall and cause tamponade. So after this, you hold the system and take the sheet forward, dilator forward, sheet forward. And once your sheet is in, you direct it again towards the mitral valve. How to do it? Because when you are puncturing, you are directing your needle at 5 or 6 o'clock. You redirect it at 3 o'clock, it means that you are bringing it towards the mitral valve again. So once your system is inside the LA, डॉक्टर ताहिर सगीर का एक जुमला होता था बार बार, एंटी क्लॉक करो, एंटी क्लॉक करो. एंटी क्लॉक मीन्स कि you by convention you have clocked, rotated it clockwise, and you have pushed the system towards the posterior wall. But now you want to come back again and come towards you and cross the mitral valve. So there will be more chances that if your system is directed again towards 3 o'clock. So once you are in the LA, you will push the system at 3 o'clock, rotate it, and then further. Usually, again, you come after this one, we come back in our conventional working view, which is usually RAO 30. In this view, you push the system forward, and if you can easily cross this shaft, it means that you are free into work into LA. But another important thing is that most of the time, once you go in, your system tends to rest into left atrial appendage. You will see in this next image, because if your system is into left atrial appendage and you push your wire, it may cause perforation of the appendage. So like in this one, if you see from the beginning, the wire tended to go into appendage. You pull the wire and then pull the system, it drops towards the mitral valve. It was in the appendage, but then it dropped into the mitral valve. So we try not to push our wire or system when you are into LA appendage. It's a frail part, you can cause tamponade. So once your system is in, then septal dilator. Dilator is usually 14 French, and there are a few precautions. I just give you one thing. This bronchus, left bronchus, is running at the superior border of LA. But you can see hard shadow above it. This is aorta, pulmonary. So never try to push any hard thing above this bronchus. This is your last limit. Even if you can see your hard border outside, this is not made up of LA. This is deceiving in angiographically, because left bronchus is over the top of left atrium. It is resting over the left atrium. So this left bronchus shadow is your last limit. Although you can see your wire, you can see something going in, but never take a hard thing beyond this part. Okay, next, sir आप आइए, डॉक्टर इरफान जी. ठीक है, अब आगे डॉक्टर इरफान आपसे फिर आगे फर्दर इसका डिस्कस करेंगे.
क्या नहीं, ये कौन सा है?
ये फॉरवर्ड.
अच्छा
ये बैक.
अच्छा ठीक.
ये पॉइंटर इससे से.
अच्छा ठीक. Bismillahirrahmanirrahim. Dr. Naveed made my job easy. In the last session, it was made too easy that I couldn't talk. But this time, it was easy that he went to the up to the septal puncture. Can you load my presentation? Although I will go beyond the septal puncture, but let me talk some thing regarding the axis. We go with the femoral vein axis and femoral artery axis. We usually save one sheath and we just put the dilator of the sheath into the vein. We remove the wire, this short wire, and we then put another 3-2 wire. So that is usually stuck because the iliac vein is tortuous and then it is stuck. So the tip is that you withdraw that. So okay, my presentation is there. So PTMC beyond the boarding pass. I mean that the indications according to the guideline, the suitability for PTMC according to the Welkin and the commissural score, and if it is attempted with a clot, then the Manjonath, that has already been dealt with. No disclosures. So when the patient comes, so far, that's the final check before takeoff. You rule out mitral valve calcification. As Naveed said, we should have a baseline picture of the heart. So we take this picture in PA view also, and also we map the heart and also look for the calcification. At times the calcification is not reported on echo too much, and it is there on the fluoro right there. So if it is there, you don't put anything and you just accordingly decide. You quickly check the TE report, the coagulation profile and the inventory, and check if there is, some people give pre-op antibiotic, others don't. So balloon sizing, this can be according to body surface area and height, or can be echo-based. So I skip. So when you go, there are some obstacles to your, as I explained, you can be, the Mullen sheath can be stuck, or the wire can be stuck in the venous system all along. So it can be in a tributary or it can be in a tortuosity. So the trick is that you just pull back and push the wire and the thing will go there. The other way which I encountered is just this this kink in the just below the SVC. So at time it becomes very difficult to push your Mullen sheath here, and this is, as I have shown, this is the RA appendage, and this is stuck somewhere there, and then you rotate the Mullen sheath towards the right. And you can see there was some impression that there may be some kink, but the SVC is okay. Now, whether to go with a PFO, we usually go with a PFO. So on this side, there is less effort. You just firmly keep your Mullen sheath and you feel the pulsation and you push it. With slight pressure, you go inside. But if you are going for the puncture, then it's better. This is a 10-year-old girl. For her, we did the LEO phase, and we just saw the LA in the LEO phase. Then, as Dr. Naveed mentioned, we stained the interatrial septum, and then we made the puncture. Here the needles come out, and here the needle is inside the Mullen sheath. So that is PFO versus puncture. So usually we at our center, we do 80 to 90% of our cases with PFO. PFO, you know, that's a probe patency of the. So this Tariq Ashraf will be demonstrating, but I have made it a video. This is a simultaneous. You remove the stretching tube, this is the gold and that is the steel stretching tube, and here simultaneous shape of the balloon you can see. When you are removing this is deslenderization from straight, slender and rigid to curved, thickened and flaccid. Actually, when we are crossing into the femoral or into the septum, we need a very slender and thin, rigid structure to cross. And as soon as we enter the left atrium, then we need a shape which can be shaped according to the stellate or according to the LA wire. So now whether you want to go with a curve or a loop. If you want to go with a loop, rotate anti-clock. If you want to go with a curve, with a loop, reverse loop, then rotate anti-clock. But mind you, if this is not coaxial, this will be hitting the anterior leaflet of the mitral valve. And this complication is not that rare. You can see the leaflet rupture. You can see in diastole there is elysing. And in systole, again, there is elysing. So that's a puncture in the mitral valve leaflet. So this is not that rare. So be careful. When it's passing like this, just push the stellate a bit in and withdraw the balloon catheter a little bit. So that will be in line with the, or if it is not possible or you are not going to align this thing, forget about this. You go and do another higher puncture and go with the curve. Again, this is slenderization or re-slenderization. When we come out, again, we need the same slender balloon. So we insert these tubes in the golds and the other stretching tube, and the thing elongates. At times, this may be necessary when the balloon is stuck in the interatrial septum. At times, it is stuck. You either prematurely remove these things, the balloon is not yet in the LA, or you vigorously manipulate and the thing is stuck here. So what you do, if you just push it more, it will come out and causing another big ASD. So you just put the wire, the stretching tube a little bit, and then the thing will get straightened and go in. Now, taking the wrong route. So at times, this may be looking like the balloon is in the LV, but there are no pulsation, no PVCs, and if you give an injection, you can see that this is the pulmonary vein, and if you inflate here, this will be a catastrophe. Then there is, you should make sure that you are looking into orthogonal views. If this was apparently looking quite well, but when you just inject, you see you have perforated. And the other thing, the differential of this is the gravitational layering. Here the dye is swirling and coming to this, but it is, as the patient is lying on his back, so LA is posterior structure, so posteriorly the dye stays there, and that is gravitational layering, and that can be confused with perforation. So at time, you may have difficulty crossing the balloon across the mitral valve. The patient may be tall, balloon may be short, and the LA may be big. So you can, and the other thing is that if the LA is too big, the septum bulges on this side, and you have to have a puncture which is lower down. You cannot go here, and here the needle slips. If like this, so it will be slip above. So you cannot make the puncture on the right place. So lower puncture, for that you have to go with a loop, and the loop may fall short, and you can go with a wire. So these are the options to cross the mitral valve. This can be, you can go with a curve in the LA, you can go with a reverse loop, or you can go with a wire support. The wire support can be just wire in the LV, or a free wire in the descending aorta, or AV loop, or you can make a pseudo AV loop. Pseudo AV loop, we have done cases with, like we bring the wire to the right arm, and we apply a BP cuff, and then that hold the wire, and the mitral valve is crossed with a loop. And then a trapping balloon can also do the same for you. So you can go with a curve, with a loop, or with a wire support, you can cross the mitral valve. Here I stop, and we will do the practical demonstration how the balloon, the various part of the balloon, and that will be demonstrated in the hands-on. Because this is only 10 minutes, so I can not go beyond. Thank you.